Hello, everyone, and welcome. Thank you so much for joining us. My name is Amy Lugo. I'm founder and CEO of Lone Star Health Solutions, a pharmacy management consulting company, a managed care consulting company. So I am joining you today as session 4 of a four-part webinar series designed at helping folks who are involved with the National Student P&T competition with improve their submissions. And in years past, myself and Dr. Kristen Patty, we have been finals judges. And so we are providing you with our feedback to help improve those submissions. Today's session is on comparative effectiveness. And ultimately, we want to help you understand where is this going to fit? How is this going to help improve these submissions? It's going to help you with your monograph and in your PowerPoint submission. So comparative effectiveness is really important, right? Because it's going to inform your value proposition. You always want to ask yourself, what additional value does this new drug bring to market, bring to the table for us? And so considering comparative effectiveness is key in addressing alternatives in your background section of the monograph. It's helpful for synthesizing evidence to make a recommendation and developing PA criteria. It's definitely going to help you in your clinical evidence tables as well. These are all different sections of the monograph or the PowerPoint. And in informing your value prop. Again, I come back to what additional value does this product bring to the table? And it will also help you in your pipeline and market access. So what is already available and how will this new drug impact what is already on the market? Now, each of the sessions will include this evidence pyramid, and the reason is because it's so important that you understand quality of evidence, different levels of evidence from different studies that are out there. Your placebo-controlled trials that are likely what you're going to see from a new drug and how they gained FDA approval, those are going to be the bare minimum that you need to share in your monograph and PowerPoint, right? The randomized controlled trials. But what else is out there that's available to help us with comparative effectiveness? Those are going to be systematic reviews and meta-analyses. Now, in years past, we've noticed that there's not been enough of that focus on those products when, if they're available, you need to evaluate them and include them. This is one reason that we're doing this is, again, comparative effectiveness is so important. And if they've only been compared to placebo, then you have to take the next step and look for systematic reviews and meta-analyses. Now, I mentioned that. So what else is out there? Of course, head-to-head studies are valuable, but how often do they really happen? Not very often, but of course you're looking for those. And real-world evidence. That's going to be helpful in considering what additional value does this product bring. And then also you want to look the pharmacoeconomic literature and looking for cost and value. What does ICER have to say about this? Are there any other pharmacoeconomic information that informs your value? So now I want to go through an example of each of those that I just went through. I'll start with head-to-head because this is ideal, right? But so often we aren't going to find head-to-head studies. Fortunately, in the diabetes space, we have started to see a pretty standard where you'll see at least one active comparator study. Now, I don't have time today to go into the difference in a head-to-head study versus an active comparator study, but an active comparator is your best sort of clue into kind of head-to-head, how would these products have favored. I've got two here on the slide for you, these tirzepatide versus semaglutide and tirzepatide versus dulaglutide. I do want to point out, and this is what you would do as you're presenting the information, there are limitations to every study and every study type. And you just need to either put those on a slide or verbally mention them. So here, neither drug was used, active comparator drug, semaglutide or dulaglutide, was used at its highest dose, right? That would have been ideal when comparing it to a new drug, the maintenance dose there. But notice how the baseline A1C, change in A1C are listed there, and it's a nice way in this active comparator study that's very similar to a head-to-head to evaluate the primary endpoint. Another way is by looking at systematic reviews and meta-analyses. So this example is in myasthenia gravis, where I'm showing you, this is a recent evaluation of the literature. I pulled 5 systematic reviews and meta-analyses. I'm displaying all of them, the overview of all of them here on the slide, including basics of the overview of the study, the journal they were published in, the year that it was published, and the drugs that were compared in that study. I've decided to dig in a little bit deeper into the MA study, and because it's a recent one and it included the most drugs compared that I was interested in. So let's dig into the MA study. Again, this is an example of how you can display systematic reviews and network. This is a network meta-analysis of 13 randomized controlled trials. All of them were placebo-controlled trials in adults of 870 folks. The average duration of follow-up was 20 weeks. And notice how I've included the treatment arms. Again, there's 10 drugs that were included. 5 of them were complement inhibitors. Excuse me, 3 of those 10 were complement inhibitors, and 3 of them were neonatal FC receptor inhibitors. These are all drugs that are used in refractory myasthenia gravis. The great thing about a systematic review and network meta-analysis is, again, we don't have any head-to-head studies in this disease state for these advanced refractory drugs, but there were a ton of systematic reviews which can inform our comparative effectiveness because they're all including and looking at the same primary outcome, the QMGS here, which is the quantitative myasthenia gravis score, and the secondary outcome looking at ADRs. So I've included a quick summary for you there in the bottom row of the efficacy. And I like to keep things simple. You can use equal signs, greater than, less than signs. You can include, if you're allowed to, a picture of results, maybe a tornado plot, whatever it is that you're able to present on a slide. But notice how I've got, just keeping it simple, batoclimab had the best efficacy and safety. It was ranked first out of the 10 drugs. Eculizumab was ranked second. Nipocalimab had the worst efficacy. And then I went into the safety. Except for batoclimab, the incidence of adverse events for the remaining drugs was not statistically significant. I've got the limitations that are listed there for you. But notice how, while there's no head-to-head studies, which would be ideal, I was able to dig into a systematic review and network meta-analysis to have some sort of discussion around comparative effectiveness and value. Another example I mentioned, looking at the pharmacoeconomic literature, we see 2 of them recently published here, Gordon Smith and Tice. And this kind of, again, is going to inform comparative effectiveness, inform value. So the Tice study is actually the ICER review published, one in Journal of Managed Care Pharmacy, but that one only included 2 drugs. So I decided to dig into the Gordon Smith study for you to, as an example of pharmacoeconomic literature and cost analysis and value. So this one was published in 2024 and included 4 different drugs that were compared. This was a network meta-analysis of 6 randomized controlled trials. Now, all of them were placebo-controlled in adults except for 1 non-inferiority study. The drugs included were this efgartigimod, both the IV version and the newer sub-Q version, rosolanixizumab, ravulizumab, and zilucoplan. One of the cool things about this study is it looked at number needed to treat and number needed to harm, as well as this cost evaluation called CPIO, or cost per improved outcome, looking at something that all of these drugs evaluated, either a 3-point or a 5-point or greater reduction from baseline in these 2 endpoints, the QMG and the MG-ADL scores. So I've looked at, included the results here for you. Again, I like to use, keep it simple, right? So efgartigimod IV had the lowest number needed to treat versus placebo in that endpoint. Rozanolixizumab had the lowest number needed to treat for that endpoint that I've listed there. Number needed to harm versus placebo was similar. We can see that the IV version had the lowest CPIO among all treatments. And also keep in mind a sensitivity analysis will likely be done in this pharmacoeconomic type of literature. They found that the sub-Q and the IV version of efgartigimod had comparable numbers needed to treat and CPIO values. Again, this is an example of pharmacoeconomic literature that informs our value proposition. It gives us an idea about comparative effectiveness, and this is really important when you don't have any head-to-head studies. And the last example I wanted to show you is real-world evidence. This one is from in the space of opioid use disorder and alcohol use disorder. This was a US retrospective cohort study, and it was completed between 2014 and 2022. They looked at claims databases here, and they found 500,000 folks with a history of OUD and over 800,000 folks with a history of AUD. They were included in the study. They had to be 18 years or older with an average age of about 50. Now, the way that they looked in this study was presence or absence of a GLP-1. Notice the GLP-1s that were included, a whole slew of them there, including our newer Sema and tirzepatide. The endpoint that they evaluated was incident rate of opioid overdose in the OUD cohort and alcohol intoxication in the AUD cohort. And they wanted to know whether a GLP-1 was improving these rates or decreasing the rates of opioid overdose or alcohol intoxication. They did stratify the results based on folks if they had type 2 diabetes and obesity. And I showed you the results here in the bottom couple of rows. What they found was that use or presence of a GLP-1 in the patient's prescription history had a decreased risk of opioid overdose in the OUD cohort and had a decreased risk of alcohol intoxication in the AUD cohort. So again, I'm showing you this because this is real world evidence and how you can use this to inform your value proposition for a certain product. Going back and thinking about that evidence pyramid, a cohort study is a lot lower on the quality of evidence, but it does give you an idea of how to incorporate a different type of study. You can point out the limitations, but real world evidence is helpful in considering likely there aren't any head-to-head studies here for this particular type of disease state with OUD and AUD. In summary, evaluating comparative effectiveness is truly a vital step to understanding a new drug's value. Just because something, this might be shocking to you, but is FDA approved, it doesn't mean it adds value to what we already have available. Being better than placebo is all the FDA requires for a drug to be deemed efficacious or to be FDA approved. So the FDA requires 2 placebo-controlled trials to be submitted. So now it is your job, though, to dig deeper than the placebo-controlled trials used for approval to determine where does it fit in therapy and what additional value does it bring to the table. Remember the evidence pyramid whenever you're selecting your studies, whenever you're to show comparative effectiveness, and consider which studies are most robust. You don't have to include everything, but you do need to consider going above and beyond the placebo-controlled trials. Now, with that in mind, thank you so much for joining us. And there are a lot of resources available on the 2025 P&T competition page. You can find that on the AMCP Foundation website. There are sample drug monograph there. You can find the Managed Care Pharmacy Primer Series there, a guide to the competition. Remember that student membership is required to participate in the National P&T competition. You have to be an active paid member. Visit the AMCP Student Pharmacist Center as well, where you can find lots of information about APPEs and leadership programs, mock interviewing, mentoring, webinars, student awards, and all sorts of other great stuff. And then lastly, visit the AMCP Foundation website, where you can find information about scholarships, grants, managed care residencies, all sorts of great things. If you have questions about the National Student PNT Competition, contact pt@amcpfoundation.org. And with that, we really appreciate your attendance today. Thank you so much.